from different hospitals to learn about their practices and to learn how we can improve the infection control related processes in our facilities, learning from others. So mostly we were talking about protecting patients, how we can avoid additional harm caused to the patients, especially harm related to infection control. So today we thought we should also talk about staff, because infections, they do not differentiate whether it's a patient or a staff member. Infections bear the same risk for everyone. And today we wanted to listen to our speakers and learn more on improvement techniques in these specific areas. Basically, how can we care for our carers being one of the most important assets of every hospital. So now I'm happy to introduce the first speaker, Chua Gek Hong, a registered nurse and Chief Infection Control Officer from IHH Healthcare Hospital in Singapore. Chua Gek Hong, you're welcome.
Thanks, Julia, for your kind introductions and inviting me to be part of this webinar series. A good day, probably also good evening, everyone. Well, for today's All right, I will give a brief introductions to our IHH Healthcare Singapore hospitals, then followed by immunization program for healthcare workers, and followed by exposures to chickenpox and PTB, how we manage, and lastly, the clinical shock injury. Okay, IHH is the actually largest private healthcare provider in Singapore that operates over 700 beds across the 4 hospitals. So the 4 hospitals in Singapore are Gleneagles, Mount Elizabeth Novena, and Parkway East Hospital. And there are more than 50 primary clinics as well. Now the immunization program, before I start on this, I would like to share 2 key words, that is vaccination and immunization. Vaccination describes the act of receiving a vaccine. Immunization is the process of becoming immune through vaccination. However, please take note that these vaccinations and immunization, both words can be used interchangeably. Now, the immunization program is the essential component of infection prevention and control for this for healthcare workers. All healthcare workers are the backbone of the healthcare system. They are at the greater risk of exposure for infectious diseases because of their contact with patients and infective materials in their working environment. And infected healthcare workers also have the risk contributing to nosocomial transmission of diseases to vulnerable patients. Thus, it is essential that both employers and healthcare workers have shared responsibility to prevent transmission of vaccine-preventable diseases. Screening and vaccination should be included in the pre-employment medical clearance requirements. There is a need to consider, should the healthcare workers actually complete all the vaccination before they start work? Of course, that will be ideal. Or actually allow at least have received first dose of the vaccinations before they can start work. Hence, respective institutions required to decide, considering the pros and cons, and then depending on the respective risk assessment, as there are times that healthcare workers also require to come on board early or urgently for essential services. Another group that must not forget that is the existing healthcare workers. Both screening and vaccination should also make available for them. If there is outdated vaccination, like such as from voluntary vaccination changed to mandatory because that is required by local act, or should there be existing healthcare workers who may not have received all the vaccinations due to pregnancy or other reasons? The institutions could provide opportunity to catch up with this group of healthcare workers. Thus, to plan and organize an immunization catch-up program for existing healthcare workers. They can be offered on site to facilitate convenient access for them to get the vaccination. If not otherwise, at least somewhere nearby and convenient for the healthcare workers to access. Ideally, all recommended vaccines should be free of charge for healthcare workers, with costs actually covered by the respective healthcare institution. Next is to ensure that the immunization record is maintained for each healthcare workers and the records made available for future reference. And there's also a written policy for the immunization program. The objective of the immunization programs is what we want to protect the staff against vaccine-preventable diseases, such as the mumps, rubella, measles, varicella, hepatitis, and so on, so that we also could prevent transmission from healthcare workers to vulnerable patients group. This is fundamental to sustain or strengthen the healthcare system and prevent potential outbreak to vaccine-preventable diseases. Now, the policy is to include the list of recommended or required vaccination for healthcare workers. Ideally, all healthcare workers should be fully vaccinated to protect themselves, as well as their patients and their family. However, certain healthcare workers are at higher risk of exposure due to their virtue of work with patients or body fluids contacts. This requires an occupational health risk assessment to determine the level of exposure of the different works or tasks involve healthcare workers to pathogen causing the vaccine-preventable diseases. The policy may recommend more strongly or require vaccination for specific category group of healthcare workers with high risk of patient group. The attached table gives you an idea on the different risk categorizations of healthcare workers. For the very high risk category of healthcare workers, work in clinical areas that admit patients with high risk of severe diseases. And this could also include intensive care units, transplant, oncology wards. The high-risk group of healthcare workers involve a direct physical contact with patients or infectious materials, or healthcare workers without physical contact but would have possible acquisitions or transmission of diseases that are spread by respiratory means. The low-risk group refers to healthcare workers who do not have contact with patients or not working in clinical areas. It can be challenging to identify and ensure appropriately categorize the healthcare workers as there are long lists of different designation or title with different job scopes, thus requiring to work with your human resource colleagues on this. In my institutions, the immunization program actually applies to all healthcare workers that work within hospitals or the clinic's premises, hence streamlining on the categorization of healthcare workers. The recommended vaccination can be voluntary or mandatory or mixed approach vaccinations. Voluntary vaccination is to leave the compliance to the discretion of the individual healthcare workers on the recommended vaccine. Unfortunately, these vaccination policies will result in a lower uptake rate, even with educational efforts to healthcare workers on the benefits of vaccination and having measures to convenient access. Although voluntary, we may consider implementing a strategy use soft mandates. For example, healthcare workers may refuse vaccination, but they are not allowed to deploy in high-risk areas and may affect their deployment and career opportunities. Also consider implementing to sign a waiver or the declination form. They undertake the risk involved. They understand the risk that they involve and to undertake also full responsibility of consequences for refusing vaccinations. Mandatory vaccination is making the vaccination a legal or regulatory requirement or a prerequisite for employment. Generally, mandatory vaccination is with higher uptake rate. There is also an argument that it is professional ethical duty for healthcare workers to be vaccinated to ensure safety for the vulnerable patients. Hence, it is not a choice, but it is actually respective healthcare workers' duty of care to ensure that they are protected from vaccine-preventable diseases so that they can protect others and patients under their care. Having said that, there is also a need to consider healthcare workers who have valid medical exemption and to have alternative plan for this group. For example, can they continue to work in high-risk areas? The mixed approach vaccination is applying both mandatory and voluntary approach. It could also adopted where mandatory vaccination applies only to certain categories of healthcare workers with higher risks of exposure or caring for a high-risk group of patients, while a voluntary vaccination applies only to the remaining categories groups. If adopt mixed approach vaccination, the policy should be clearly and unambiguously define the healthcare workers groups and work areas. My institution actually adopted the mixed approach vaccination because we are required to comply to certain mandatory vaccination as required by our Healthcare Service Act. And also we use the soft mandate voluntary vaccination for other vaccine, where healthcare workers are to sign letter of indemnity for refusing vaccination. They are not allowed to work in high-risk areas and also to take full responsibility on all consequences. Generally, this happens to existing staff that we may need to consider reassign deployment area. For new recruits, it has actually become a prerequisite for employment. In this next few slides, I will share on this recommended vaccination for healthcare workers. Our Ministry of Health Singapore also does provide recommendations on the type of vaccination for healthcare workers. Besides recommendation from our Ministry of Health, measles and diphtheria immunity are now a mandatory requirement by Healthcare Service Act for healthcare workers who are working within the hospital or clinic premises. Hence, it includes staff not working in the clinical areas, such as the HR personnel, the human resource personnel, and those staff that working at the back end office. Before proceeding with the required vaccination, there is also need to check individual for acceptable evidence of immunity. Self-declaration is not acceptable evidence of immunity, thus required to have evidence proof. As you can see from the table, it provided guide what are the acceptable evidence of immunity, and if no immunity, how many doses of vaccines are required. Let me bring you through example the tetanus, diphtheria, and pertussis require documented proof of vaccination with Tdap or TD vaccine in the last 10 years as acceptable evidence of immunity. If no immunity or have no previously received Tdap, then the individual required to receive 1 dose of Tdap and followed by TD booster is recommended every 10 years. It will be good if respective institutions has a robust systems to follow through on this. Otherwise, we'll fall back on manual catch-up on this. For the measles, mumps, and rubella, the acceptable evidence of immunity include documented proof of vaccination or serologic evidence of immunity against the 3 diseases. Take note, it's 3 diseases, not 1 or 2, or the laboratory confirmations of all 3 diseases. If no immunity, then require 2 doses of MMR vaccine with at least 4 weeks apart between the 2 doses. However, if individual receive 1 dose of MMR previously, he or she can proceed receiving the second dose as long as the 4 weeks lapse from first dose. There is no need for post-vaccination serology tests. In our Healthcare Service Act, it allows Singapore citizens or permanent residents who born in Singapore and before 1975 are exempted from the measles vaccination. This is because a seroprevalence study showed that there is high level of immunity against measles in this group of persons. Hence, depending on your respective country, if there is any other exemption guide for vaccination. Having said that, do note that it is only exempted from measles vaccination, but not the mumps and rubella vaccine that are still recommended for healthcare workers. For hepatitis immunization is recommended for all healthcare workers, particularly if healthcare workers who perform exposure-prone procedures. Now, what is exposure-prone procedure? It is defined as those invasive procedure where there is risk that injury to the worker may result in exposure of the patient's open tissue to the blood of the worker. This procedure includes those where the worker's gloved hands may be in contact with sharp instruments inside a patient's confined anatomical space of open body cavity or wound where the hands or fingertips may not be completely visible at all times. And open surgical procedures are considered as exposure-prone procedures. Healthcare institutes should assess respective individual practices within their local institutional context to ascertain if the healthcare workers do or do not involve exposure-prone procedures. Acceptable evidence of immunity for hepatitis B include documented proof of vaccination and post-vaccination serology with protective antibodies of equal or more than 10 MIU per mil. You look busy with words for the vaccination column. Let me bring you through the next slide on the flow chart instead. If the healthcare worker does not have acceptable evidence of immunity, he or she is required to have primary 3-dose series of hepatitis B vaccines at 0, 1, and 6 months interval, followed by post-vaccination serology tests within 1 to 2 months after completion of the 3-dose series. Look at the upper diamond's shape. If the post-vaccination test result is 10 or more, it is a responder or have immune response, then there's no further action required. Refer to the lower diamond's shape. If it is a non-responder or no immune response, whereby post-vaccination serology result is less than 10, there are 2 options. First option is to give another booster dose, then check serology again. Option 2 is to complete second cycle of 3-dose series vaccinations, then check serology again. For option 1, if still non-responder after the booster dose, to proceed with the second and third dose of vaccination. In summary, if remain non-responder after 2 cycles of 3-dose series, healthcare worker is to refer to occupational health physician. For our institution, we refer to the infectious disease physician for further counseling on the risk and susceptibility to acquire hepatitis B virus infection if he or she is involved in exposure-prone procedure. So in such a case, we need to consider redeployment of the healthcare workers. Now for varicella that is referring to chickenpox require 2 doses with at least 4 to 8 weeks apart if no acceptable evidence of immunity. The acceptable evidence of immunity is listed in the table. We also conduct on-site annual influenza vaccination exercise at least once a year for our hospital staff. We may conduct half-yearly depending on our MOH recommendations. In IHSG, we included meningococcal vaccine for our laboratory staff who actually handle plating of specimen cultures with potential risk exposure to Neisseria. This vaccine is recommended 1 dose for every 5 years. However, due to the time constraint, I should not go in details about chickenpox, but however, I think we should be aware of the transmission mode, the contagious period, incubation period, to help us how should we manage if staff are exposed to chickenpox. The transmission mode for chickenpox is airborne and contact. Contagious period is 1 to 2 days before the rash appears until all the lesions are dried out. Incubation period is 10 to 21 days. As in the flow chart, we need to check and ensure that those staff being exposed, defined as having contact with insects or share the same airspace in a confined room with the insects, to have acceptable evidence of immunity. If yes, no further action required. If no, for example, that those that not taken the vaccination for reason, then staff will be sent for a serology test to check if the staff has the immunity. If positive result, there's no further action required, but if negative result, to proceed with 2 doses series of vaccine. Respective healthcare institution should assess and decide if to take the staff out from the patient contact, which means from the clinical areas, or to be on home leave to watch out if the exposed staff does develop the infection. For our hospitals, we will take out the exposed staff who have no immunity from patient's contact. From the day 8 after the first exposure date, till the 21 day after the last exposure date. This staff will deploy to work at back-end office. It will be up to 28 days if staff receive immunoglobulin as prophylaxis, as immunoglobulin can delay the onset of the symptoms. If staff had previously received 1 dose of varicella, to proceed with the 2nd dose, and there's no need for work restriction. For the transmission mode for PTB is airborne. Active or infectious PTB is actually contagious even during the 2 weeks of treatment. After 2 weeks of treatment with clinical improvement, then we may consider as non-contagious. Generally, incubation period is 2 to 10 weeks from exposure to the development of positive screening results. Screening criteria includes the following that are without respiratory protections, as healthcare workers performing or assisting high-risk procedures associated with aerolization, such as bronchoscopy, intubation, suctioning, or healthcare workers performing assisting procedures there's not aerolizations that is 8 hours or more without respiratory protections, or a person who shares the same airspace in an enclosed environment, for example, the air-conditioned room, for 8 or more hours accumulating exposures to PTB. The three, now I come to a clinical shot in, sorry. All right, sorry. All right, so I will come to this healthcare who exposed to the active PTB. Healthcare workers who exposed to active or infectious PTB admit the screening criteria and also do not have prior TB disease or latent TB are to have actually baseline tests, either the quantiferin test or tuberculin skin test. If result is negative, to repeat screening 8 to 10 weeks time. We refer healthcare workers to respiratory or infectious disease physicians for further evaluations and management if results of the quantiferin test is positive or the tuberculin skin test is 10 or more millimeter. Right. Now I shall touch on the clinical shock injury. Now the 3 primary concern for blood-borne infections after clinical shock injury, the risk of seroconversion from source positive result are about 30% for hepatitis B virus for those that without hepatitis B immunizations, about 3% for hep C virus, and about 0.3% for HIV. What is high-risk sharp injury is one in which there is a deep injury and large blood volume or large hollow bore needle used in source patient's veins or artery, a used needle or sharp objects with visible blood during an invasive procedure, or any deep injury resulting from used needles or sharp objects with visible blood or potential injections of blood. Now, in the hierarchy for sharp injury preventions, first priorities is actually to eliminate or reduce the use of needles and other sharps where possible. Next is to isolate the hazard, thereby protecting an otherwise exposed sharp through the use of an engineering control. Next is to isolate the, when the strategies that are not available, the above strategies that are not available or will not provide total protection, the focus will shift to work practice control and personal protective equipment. With that in mind, I've actually listed some tips to protect self from sharp injury. One of the important aspects is to stay focused when handling sharps, avoid distractions when this handling of sharp, and then avoid rushing as well. Next is to ensure sharp board is available for use so that staff could bring it along. And it's not just only about bringing it along, but must place in a stable positions and also within reach so that to allow immediate disposals of sharps. Do not leave used sharps for others to clear. The person who used the sharps should be responsible to clear the sharps. If this is not possible for a reason, always check for sharps that may be left behind on surface or trolley after procedure by using a forceps instead of bare hand. Do not overfill sharp box, which means that do not continue disposing sharps into a sharp box when it's 3/4 full. The sharp box should ensure close tightly for disposal. Avoid recapping needles. Always dispose the needles and strings as one unit. Do not try to detach the needle from the syringe. Use the hand-free technique when passing sharps, such as using a receiver, tray, or a neutral zone. If using a receiver, be mindful not to expose your fingers actually above the receiver. Use verbal alerts when passing or moving sharps, especially when during the surgery. Patient may suddenly jerk or move during procedure like injections or insertion of cannula. Hence, always ensure cooperation from patient by informing them about possible pain or sensations and advise patient not to move during the procedure. Do not cross path sharp and do ensure correct hand positioning. Be aware of others around you during the handling of sharp. Do not accidentally break others. Last but not least, do use sharp with safety device whenever available. But healthcare workers who sustain sharp injury are advised to wash hands or cups under running water and apply appropriate dressing. They are to report the incident to their supervisor and infection control personnel. They are to seek medical treatments and management at our urgent care center. For other institutions, refers to occupational health clinic if you have. Blood screening for hepatitis B, Hep C, and HIV will be obtained for the healthcare workers. On the other side, if know who is the source patients, inform patients' principal doctors to obtain patients' blood tests for HIV, Hep C, and Hep B surface antigen. Prophylaxis may require if the injury deems to be high risk. Healthcare workers are to follow up at urgent care center for subsequent blood tests 3 months and 6 months later if source patients HIV and Hep B are positive or the source patient is unknown. Our doctor from UCC may decide to refer healthcare worker to infectious disease physicians for further management and follow up if source patient is HIV or Hep C positive. My team will also interview healthcare workers to understand how they sustain the sharp injury and work with relevant personnel on how could such injuries or incident can be prevented. These are the references that you may take on the details to develop immunization program and the sharp prevention program for your institutions. With that, I thank you for your attention.
Thank you. Thank you very much, Gek Hong. This is very helpful, and thanks a lot for all the references and all the details and the very clear criteria that you provided. I was actually listening to you and I was thinking that for our audience, it's a ready to use instruction, basically, if they want to implement or to improve and revise their staff protection program, they can just print out the slides or just literally copy paste it into their policies and procedures, because the criteria for vaccination, for testing stuff are very, very clear and very useful, and there is no double meaning and no challenges interpreting it. Also, thanks a lot for providing very clear instructions on how to handle needle stick injuries, also with safety features that you and safety techniques that you provided, because this is also very helpful to revise over and over again stuff about this. And these data, these points, bullet points, can actually be printed out and put on the wall in each medical room. Like, for example, not to recap the needles. This is something which is recommended by the global best practice, but unfortunately is often forgotten by the staff when they work with sharp objects, as well as the recommendation not to overfill the sharps and needles containers again, it's for the very same reason, so that nothing falls out and damages, first of all, staff, and secondly, it might also be dangerous for the patients. So please always remember that sharps and needles containers should not be more than 2/3 full. And this is something we keep repeating to you when we visit the hospitals, to you as medical staff, I mean. So these were the recommendations for a hospital, big hospital, but in each hospital there are specific departments where even additional measures need to be implemented, because basically staff every day work with human samples, and this specific department is lab. And I'm happy to introduce our next speaker, Manuel Giralde. I'm sure many of you met Manuel before. If you attended our webinars, he already was a speaker before. Also, he is a part of our team of assessors. So maybe you even met Manuel in person. So Manuel, the floor is yours. Please tell us about specific precautions in the lab.
Well, thank you, Julia. Let me just put the slides and I'll talk. Let's do that. Can I get a confirmation? Hi, can I get a confirmation that the slides, you can see the slides?
Yes, we can.
We can see the slide.
All right, thanks. Good morning, good afternoon, everybody. Thanks, Julia, for passing the phone call, the microphone to me, and thanks, Chua, for the excellent presentation and information about vaccination for hospital healthcare workers. You mentioned a few points about lab people as well. I saw that one of your slides was related to meningitis and the importance of having this vaccine, especially for people who handle specimens in microbiology. So thanks for that. I'm gonna focus a lot on well, we're gonna leave on the side now vaccination, because she already covered most of the things that I really wanted to cover from the vaccination side. So we're gonna focus on other protective means that we should have in place when we work in lab environments, in microbiology, in chemistry, in all these areas, but mainly gonna focus in bacteriology and virology and parasitology. Those are the main areas related to infection control. So my name is Manuel Giralde. I've been working in healthcare, in lab medicine for the last 35 years. I'm working in different hospitals, in teaching hospitals in Toronto, mainly, where I have worked as a lab scientist and also in management positions and quality positions as well in hospitals for the last 15, 20 years in those areas. But also I have the honor and pleasure to work with international organizations that accredit hospitals or assess hospitals, and one of those is IFC, and we work with a healthcare team of more than 20 healthcare professionals. So very pleased to be here with you today. And I saw when we start the webinar, I saw a number of teams joining from many places that we have discussed and we have visited or we have assessed their organization. So hello to them, just my greetings to them. Okay, before we start with diving into the lab means to protect the staff, let's talk a little bit about facts, and let's review a few things that I wanted to bring to your attention. It is estimated that 500,000 employees, lab workers in the United States are at risk of exposure to infectious agents that cause disease ranging from inapparent to life-threatening infections. And then there was a study conducted about 4,000 laboratory-associated infections that acquired infections that were almost 2,500 occurring in the United States, and 164 were fatal. That's a lot, right? When they did this study, they found that 164 of those were fatal. And an analysis available revealed that 18% of the infections were known to accidents, but 42% were known or caused by bacteria, 27% by viruses, 15% by rickettsia, 9% by fungi, and 3% by chlamydia, and 3% by parasites. So I left the sources in case you have resources. If you want to go and look into those details, you can see that. But here's the bottom line is the bottom of this screen. You can see it coming from a research done by Byron and Miller that indicated the most common organisms that are acquired in acquired infections are Shigella, and then Brucella, Salmonella, and Staphylococcus aureus. Those are only bacteria, but you can imagine there are also parasites, viruses, and fungi that are related to infections in lab people. So I don't have many slides, but I just wanted to take a few minutes, and I spoke to Julia. We were going to focus mainly in the lab, so my presentation will be very quick, probably about 5 to 10 minutes. But I want to say something about this part, and it's about loss and cost. A lot of people focus on quality and productivity, and yet we tend, and I work, like I said, I worked for many years working as in the lab management position, and a lot of people forget about safety. There are specific safety standards for laboratory environments, and I'll mention some of those related to infection control. But this screen is really an open eye for many of us, or many of you, hopefully. And this is related to those costs associated to when you don't provide a safe environment to the healthcare workers. And there are costs associated to compensation, medical costs, rehabilitation costs, sorry, I missed that S, loss of injury workers' wages, loss of administration time, loss of time related to hiring and training a new replacement worker, lost costs related to illegal fines or penalties that many times the facilities will be closed by the public healthcare agency, or will be visited and inspected, inspections, so on. Reputation, that's huge, and poor labor relationships, and pain and suffering to the ill employee, etc., etc. So we need to keep this in mind. That is not just related to providing a quality control, quality assurance, productivity, but also we need to focus on safety, because safety is number one. And if we provide that environment, we're going to have people who work and feel safe again, but will deliver the results in a safer manner. And when you have people sick, when you have people that you can prevent, all these things that we're talking here, most of these things can be preventable. And Shu mentioned a number of things that can be done to prevent a number of diseases that can be acquired if you don't provide this means to the lab staff. So most of the labs that work in hospitals, in facilities or standalone labs, will be classified under biosafety level 2. And those are labs that require a biosafety cabinet, especially if they handle microbiological specimens, and they do actually bacteriology procedures, such as planting, culture, and identification, isolation of those microorganisms. But let's not forget that that's not the only lab that does handle those specimens. Just because you don't have microbiology in your lab, it doesn't mean that the specimens that come to your lab are not potentially contagious. Meaning when you open a urine, if you're doing a urinalysis, if you're doing a dipstick on that urine, if you're doing open a tube, a blood tube, and a liquid it or pour into a separate tube, that still causes aerosols. Aerosols are particles that will travel immediately you open a tube or immediately you open a urine. You don't see those usually, but they're coming out of when you open a container that has fluid, has a urine, has blood. Those microorganisms or aerosols will come and will travel, and you can inhalate or a respiratory, can go through your respiratory system or your eyes, your mucus, and you can get an infection from those. So you must open those also in a hood, or at least have a shield to protect your eyes in between the specimen and your eyes or your face, right? So let's keep that in mind. Obviously, if you handle more infectious agents, then you gotta look into biosafety level 3, and those are people who handle usually in research facilities or even TB, tuberculosis bacteria that you had to handle those microorganisms under biosafety cabinet type 3. Then if you have a maximum containing that will containment that will be under biosafety level 4, and those are especially dangerous pathogens units, and maybe that will be classified with Ebola testing or things like that. All right, so I want to bring this slide to you just to mention a few biological hazards, and there again they're classified. The hazards are classified in many ways, many types. Well, I'm focusing on biological hazards, but there are also chemical hazards and physical hazards. Today is just about biological hazards, but people who work in the lab, let's not forget about chemical hazards and physical hazards. We're not going to get into that right now, but let's focus into biological hazards. For the biological hazards, let's also make sure that we divided those in 4 categories at least: bacteria, viruses, protozoa, and fungi. Within the bacteria, we mentioned Shigella, we talk about brucellosis, we talk about Staphylococcus aureus. Those are the main high-risk bacteria that are linked to associated lab infections or acquired lab infections according to literature. But then you have viruses, and Shu mentioned a few of those: hepatitis B, hepatitis C, HIV. Then there are other ones that can be not only linked through exposure due to also to your when you puncture, needle stick, or things like that, but they're all associated to aerosols such as COVID, influenza, things like that you must keep in mind as well. They're also linked to acquired infections in lab settings. Then you have protozoas, people who work in parasitology, even people who work in hematology. When they do some lab testing, if they don't protect or if they have a finger prick, they can get, and there's this literature, you can find it, has been already published, that there are things related to malaria that are associated infections to malaria, leishmaniasis, and trypanosomiasis associated to protozoas as well. And then you have fungi. Fungi is a very lethal infections, especially for coccidioides or for histoplasma or even other blastomycosis. Also, they all cause mainly pneumonia, especially for people who are immunocompromised, and they can be very bad if you don't handle those specimens properly. So people who work in mycology environments, they must protect themselves constantly against these agents, and they have to have a very careful way to handle those specimens. She also mentioned about the hierarchy of controls, and she talked about elimination, substitution, engineering controls, and admin controls, and PPE. So this is a chart that I'd like you to keep in mind, and we're going to dive into a few means that we can use in the lab to protect the lab people who work with these agents. So let's talk a little bit about the engineering controls related to lab stuff. And these are controls that you would like to use to isolate people from hazards. And on the top, I put those samples, but on the right side, you'll see the pictures related to those examples. So the first one is the biosafety hood. And a lot of environments, a lot of hospitals, and lab settings that I have visited overseas, I see that people cultivate samples in open environments. And sometimes they use a small Bunsen flame. The best practices is that today, the recommendation is to plant any specimens that you have in a biosafety hood, especially type 2. And that's because you don't know what specimens you are planting, and you don't know what's behind that specimen. Or you probably know actually what specimen you are planting, but you don't know what type of microorganism is coming out of that specimen. So and I'm thinking right now about brucellosis. If you have a brucella happening to be on that specimen, that could go into your respiratory system, that could cause brucellosis. And again, brucellosis is a disease that it could terminate in bad conditions if you don't handle that properly with fever. It can affect lungs, it can affect liver. So that the recommendation today is to plant all the specimens in a biosafety hood. I don't want to get into details, and maybe we can have a separate meeting at another time, but those biosafety hood, when I had visited many hospitals overseas in Africa and Latin America, I seen that those biosafety hoods, they're just installed, but they're never inspected. They must be inspected. At least once a year, they must be certified, and they have to be maintained to ensure that they're in good shape and good practice. So let's keep that in mind when we do planting, always under biosafety hood, and those biosafety hood, they have to be certified and maintained on a routine basis. The second on the top right is called an automated sampling equipment. So this is mainly for huge facilities where they have a large volume of specimens that they would like to have a pre-analytical robotic system that instead of handling each tube one by one and opening and liquiding and testing, you have these massive robotic systems that they can do the whole thing. They can open, decapping is called decapping, aliquoting. They can reseal again, and then can put it on the side. So if you have a large facility where you handle lots of specimens, I will recommend you to keep that in mind for your next equipment purchase. The third one on the bottom on the left is an automated planting device, especially for microbiology. If you're handling, again, many specimens, instead of doing planting individually for each of those samples, for CSF, for fluids, for urine, for blood, you can have these devices where they do automatic planting. You just put one drop of the specimen on one swab or touching the Petri dish, and it will go automatically and will do this tricking. Now, some of these devices, they do the whole thing. They open the specimen and they will do the tricking. They're quite expensive, but that's only FYI, just to keep in mind if you handle large volumes again. The fourth one is a centrifuge. It's a very common instrument, but many people don't use the lid. On some of those centrifuges that you have in your lab, they don't have a lid. The lid must be always closed, and the requirement on the international standard that today the centrifuges, they should have a lid to protect for any aerosol and even for any breakage inside. The fifth picture on the right below is just a disposal, and Shu was talking about this disposal, hard containers. One of the things that I want to call the attention to the lab professionals, to hematologists, to people who handle specimens, not only syringes, but also hematology, slice and sharps, is that you must dispose those sharps in the lab in those containers, not only syringes in phlebotomy, also those sharps such as a slice or any glass in those containers. And again, like they said, do not overfill those containers with those sharps. The last one is called a self-sheathing needle. That needle is a device that has a special recapping that you can use to protect yourself. Instead of recapping, you can do it on the side, and that automatically protects of any needle. Okay, so those are called engineering controls. Let's talk about administrative and PPE controls. So those are related to the safe personal work practices. And on the right, I have personal protective equipment. You can find all these requirements, by the way, for lab, again, for lab staff, for people who work in microbiology, under one of the ISO guidelines is called ISO 15190, 2020. They have specifications, and there are many literature related to as well as safe personal work practice. And one of the things that managers, directors, team leaders in microbiology and in the lab, they must develop policies and procedures to ensure that everybody will follow the same rules. So when it comes to that, a few things to keep in mind, and I put the clause beside the recommendations because you can find that on this ISO. But let's keep in mind that you're never gonna eat and consume food or drinks while you're working in any area in the lab, period, anywhere, you had to put a sign in front of the door that says, do not, you're not allowing food or drink in your lab, obviously, and mainly in microbiology, but the recommendation is anywhere in the lab, do not do it, do not keep it, do not store, do not consume, right? Number one, personal property. I've seen a lot of people in the lab and in many locations, again, where they actually come, they bring their own belongings, their purse, their bag, and they leave it right beside where they work in a small cabinet. They put it in their office. No, that's not allowed. Why? Because you put that right there, is in an environment that could be contaminated, and then you take that back with you to your house. Don't do that, please. Again, do not do your own laundry for your lab coats in your house. That's contaminated. You must discuss that with management. Has to be done in a separate environment in the hospital or lab facility, in a separate washing machine, or having an external company or a laundry department, or having an external company who will do specifically the laundry for you. Personal property, we mentioned that. Hand hygiene, this is very key. It will protect your staff. We know that hand hygiene will reduce significantly the infections not only in lab, but throughout the hospital facilities, even at home. So make sure that you have education, that you provide the staff with hand washing machines dedicated, listen to me, dedicated to hand washing. Do not combine dirty and clean sinks and ask the people to do both at the same time. No, you have to have a separate sink, ideally before exiting the lab. That's a requirement, again, because when you leave the lab, you want to wash your hands before you leave the lab, the last thing that you want to ensure before you go outside, right? And sharps, we already reviewed the sharps, so we're not going to talk about the sharps. Now, when it comes to PPE, depending on where you work, you want to have PPE, but you have to have minimum expectations for people who work in the lab. And again, you must put a sign on your door before entering your lab premises for everybody, for visitors, for your staff, for volunteers, for anybody who comes to your lab. You must have a policy, defined policy. The usual recommendation is to have shoes, right? And the shoes have to be fully enclosed. Do not wear sandals. Do not wear open-toed shoes. No. What happens if you have a needle or a sharp going to that toe, right? It's going to cause a potential infectious associated disease. So make sure that you have wear shoes that are enclosed, heel, front and back, and they are very well protected. Hard, ideally, sneakers are okay. Then you have your lab coat. Make sure that your lab coat, when you leave the lab premises, ideally, folks, you gotta leave your lab coat, dirty lab coat, soil lab coat, and then you have to have, if you want to go outside with another lab coat, make sure that it's a clean lab coat, or leave your lab coat and have your regular clothing to go outside the lab. Don't do it the other way. Don't go with your soil lab coat outside, because you will bring infectious diseases outside. Contamination. So face and body protection. If you're working with urines, opening urines, if you're working with blood, with tubes, planting, if you don't have those devices that I mentioned, hoods, make sure to at least protect your mucus, your eyes, when you're opening urines or tubes, so you don't have that you have that barrier for aerosols, right? And then you have to have your gloves. Again, that's minimum that you have to have your gloves and footwear. We'll already talk. So the ultimate goal for everybody is to have safe and happy people who feel comfortable and feel safe. And these are just a few recommendations only from the microbiology side. Maybe I missed a few, but mainly I focus on the bacteriological side. There are many more for chemicals, for physical. At the end of the day, what you want is you want to make sure that everybody keeps in mind that lab safety is the first priority, and the lab safety starts with everyone's, with you, with me, with people who work in the lab. So everybody has that drilled down in their brains that they had to keep that as a priority. Thank you very much. Happy to take some questions later, and I'll see you later.
Thank you. Thank you very much, Manuel. This was magnificent. So basically, just about question and answers. Thanks a lot for posting your questions both in chat and Q&A section. Please continue doing so, because we have one more speaker, and after that we will answer the questions that you post. Also, Manuel and other experts are already typing the answers, and this option is only available in Q&A button in Q&A section. That's why we ask you to prioritize using this button. Also, we actually received a question about, okay, guys, in your advertisement of the webinar, you said you're gonna touch the risks that staff have in the hospitals, how to identify them. And I think you can gradually see how we are addressing these risks. We promised to touch obvious and hidden risks, and I believe we are doing so with our speakers, because we were preparing together. So we discover with each speaker more and more risks, so they will be in the slides, and we will share the slides. Also, one of the most common questions we're getting, will we share the recordings? Of course, yes, the recordings are always available on our webpage. So you can always watch and remind yourself about the previous webinars, or if you attended or if you haven't attended, they are also available. Same as this webinar will also be available on the webpage. So thanks a lot, Manuel, for touching the main aspects of staff protection in the lab. Yes, there are key components like infrastructure, presence, and here we often see, and thanks a lot, by the way, for raising the issue of cost, because there is one thing, for instance, like eye washing station, which is often missing in many labs, and they say, what's the purpose of it? Why should we install it? It's quite expensive, the management sometimes says. So basically, here, I think Manuel in his presentation tried to show that there are no trifles in lab, and there are lots of risks about which staff do not think when they work with the samples and the specimen. Also, it's not only the availability of the infrastructure or the availability of PPE, for instance, yeah, it's also proper use of them. Because sometimes, as Manuel said, hood is available, but is not used or is not functioning, or eye washing station is not functioning, or sometimes more advanced labs have, you know, this even shower, which is activated by just very quick button or a string. So that it can be used in emergency. This is for a reason, because when the specimen touches your mucus, you need to act really fast. That's why eye washing station and showers are very useful, and some labs do not have a functioning sink. So sink is out of order. So obviously this has to be addressed as such. And use of PPE as well. Often we see that PPE are neglected in the labs. They are not used. They are available, but not used while working with specimen. And also personal belongings. Thanks a lot, Manuel. When we were preparing for this webinar, we discussed this with Manuel, use of personal belongings in the lab. Even use of the computer mouse without gloves or with contaminated gloves has to be revisited. Yeah, how you use your computer and whether you use it with your gloves and especially contaminated gloves. Also, washing your gowns at home. I wanted to stress this point. Domestic machines do not ensure temperature high enough for long enough period to kill certain types of bacteria. That's why it's never recommended to use domestic machines either in the hospital or wash your clothes at home, because it might be dangerous. So I'll pause here. This was just a brief summary to draw your attention to specific facts. And I'm happy to introduce our third speaker, with whom we wanted to draw your attention to how to adapt these specific requirements to countries less regulated or where there is less infrastructure available. So how to adapt these principles and requirements of staff protection. So our third speaker is Xavier Anton, an expert in healthcare quality and patient safety. Xavier, over to you.
Quality and QPS committees reporting to me when I was leading organizations with more than 25 hospitals over 5 countries. So as a person that cannot oversee, I cannot really overstress the importance of getting data to the leadership, because if the leadership in your center does not know what's going on, will not really be able to put the solutions in place. That may be in terms of supplies. The leadership should impulse immunization programs that have been discussed, and then also ensure that the management of exposures are addressed adequately. Of course, when we have people that may be already infected, we have to ensure that they are deployed in areas that will not be infecting patients or that will not really be putting other colleagues at risk. So it all begins with the beginning, which is really knowing the infectious risks in your hospital. So if you do have an infection control program, doing risk assessments. There are many tools that can be used and that are available through the internet, and also IFC can be instrumental in supporting you in that aspect. Uh, Policies tell us what are we going to do, and this way people can refer to the policies so that we have a uniformity in the processes that we do in the hospital. My colleagues have discussed vaccines and then some risk reduction strategies. We will discuss that in a moment. And then everybody now, unfortunately, after COVID, is very familiar with outbreak of infectious diseases. Some of the lessons learned there can be applied to other areas. However, the infectious outbreaks, whether it is MRSA, whether it is Clostridium difficile, will have different needs. Another thing that we do not often consider is sick leaves. Leadership has to support people having symptoms to be able to leave the potential contagious period, to be going home and to stay in there so that they do not make a contagion to either our patients or to their colleagues as well, which will impact then on the whole organization, correct? Just a quick reminder, in the 80s we started with universal precautions. That was basically to protect workers from HIV and to treat human body fluids as if they were all infectious. So this is interesting because in many places you see that people test preoperative patients for HIV, for hepatitis B, and the question usually is, are you going to treat these people differently? No, because we use universal precautions, correct? So all patients are potentially infectious. However, then we upgrade this to standard precautions. There are some other things that are not present in the usual body fluids. You can have lumbar punctures, you can have semen analysis, you can have bile analysis. Adequate precautions, standard precautions have to be used for the management of these areas. Safe injection precautions, some injections either intra-articular, intramuscular, are not followed with the safe practices. So training, orientation, and putting these in the front of the safe practices that employees follow to inject patients. When we do not know if these patients are infectious in these other areas, we assume that they are infectious, and that's when we do these standard precautions. Finally, transmission-based precautions may be for droplet precautions in the cases of very small infectious agents. There may be chickenpox, measles. Use the mask, of course, and then we'll discuss a moment later also. When we say that we have masks, we talk about usually about N95 masks, which is okay. But when we want to ensure that N95 masks are fitted adequately, there are simple methods with which we can do that. And the typical one is with the glucose vapor to see if that penetrates into our nostrils when people are enclosed in a plastic bubble. We have to take also the droplet precautions for mumps, pertussis, influenza, and SARS virus. And finally, the contact precautions for other things that we do not usually think about. There may be impetigo, scabies, herpes zoster, or even MRSA. Gloves, gown, and private rooms, and for these cohorts of patients, correct? Then, when we are talking about PPEs, make sure that they are the adequate PPEs and that we test. If we have the luxury of having respirators, again, as I was saying again, with the N95, we need to test them and also have them deployed in the location where they may be used. My colleague Manuel was talking about food and in the laboratory. Well, when we go around hospitals, we do see food in many patient care areas, in desks. In the emergency room, people are having coffee at night. And then also the cafeteria where the employees get their food from has to meet the necessary standards. And we're not talking about the hospital cafeteria, which may be more standardized, but oftentimes we see that cafeterias is with people that we have contracts with. So these centers or these other cafeterias are really sometimes out of the loop of infection control. So they have to be subject to the same standards of infection precautions because a lot of the healthcare workers tend not to eat sometimes to the usual hospital food or cafeteria. Another area that Manuel was also talking and is the fomites. Fomites are the things that get infected and that can transmit germs from one to the other. That may be from anything from doorknobs to mouse to keyboards and so on. And we do see that sometimes we have sanitizers available, sometimes we do not. But we have to ensure that, especially in the lab areas, that these are the adequate infectious or disinfectant agents related to the potential germs that we may be dealing with. And then another thing that we see is that yes, we do clean the telephone, we do clean the mouse, but contact time for the agents. Some typically you have to leave the things 1 minute, 2 minutes, but according to the manufacturer instructions, the different disinfectant agents that we have different contact times. That mostly applies to surfaces, and it's a common error that we spray a surface and we wipe it out without really leaving the time sufficient for the germs to be killed. Let's not forget about jewelry, bracelets, rings, long nails, and then oftentimes, the necktie from the physicians typically is one of the really dirty things. So your infection risk assessment should include all of these things. Just a couple of words about sharps, emphasizing what my colleagues already said of the adequate containers. Uh, Sometimes or oftentimes we do see containers that are not adequate in terms of being hardened, either cardboard or plastic. But also the top of the container has to be not big enough because sometimes the hand can get in there and sometimes these containers are not in secure places. Children have been known to stick their hand in there. Also, the containers are typically not secured. Container falls to the floor, has a big mouth, and then we see that the container contents are spilled in the floor. And while picking up all these agents or all the needles and all the other sharps, then people get injured or get needle sticks. So containers, but yes, containers need to be secured and they have to be safety engineered as well as the sharps that we use. So needles with self-protecting sheath that do not need to be recapped. Another thing that we see frequently in many places, especially in countries with not enough means to buy expensive containers, is the use of plastic bottles. Plastic bottles sounds like a good solution, but they are usually not secured. They are made out of thin plastic, and they usually get overfilled, creating then punctures in other areas of the bottle. It's an interim solution. Plastic bags, it's an interim solution, but it's really not what is going to help prevent injuries from sharps. So again, I cannot overemphasize attaching the containers to the wall, or if they are on top of a cart, attaching them because they do fall to the ground. They break open, and then people do get sharp injuries. difficult points for the hospital staff. We talk about vaccines, vaccines, vaccines. Well, so what happens with people that start getting influenza vaccines? So oftentimes, since they are affordable, the leadership provides vaccines for free to the staff. But then, we see that rates are in the 60% range. And so one methodology that has proved adequate to increase the rates dramatically is what is called the push and pull point of delivery or point of administration. So the technique consists of initiating the campaign, going to different areas of the hospital, providing the vaccine by infection control or whoever you want to design. So then the staff that have gotten the vaccine do get to enter through the normal entry of the hospital. However, the other staff that do not have their ID with the appropriate sticker or whatever you want to designate have to enter to another area where they get reviewed, they get information on the vaccine, and in other words, we try to emphasize the need for us or our duty to protect our patients from us. We want to protect immunocompromised, debilitated patients, patients that have COPD, patients that have other respiratory problems from us getting them. And remember that first 3 days, usually we can be asymptomatic, but we can be contagious. So vaccination is the only way that we can address this part of the infectivity during influenza season. Of course, people that do not receive vaccines ought to be deployed in areas where they cannot really make sick people that are immunocompromised. In some countries or in some areas, there is legislation, and in the US, there was challenges to the mandatory vaccination for COVID, and usually the courts upheld the employers that decided that people had to be vaccinated or they could not work there. Again, another area that we can use is when in the hospitals that do have physician evaluations, the compliance with vaccination is another point that sometimes score the physician's ongoing professional evaluation. Now it is also a Joint Commission standard that we have to have data on vaccinations. We have to have data on our improvement plan, because knowing that we have a 70% vaccination rate, if we do not have an improvement plan, it's a little bit of a hollow data. So already we have discussed at length hepatitis B and the policies for vaccination. A couple of words on varicella, tetanus, and pertussis vaccinations, and mumps or rubella. There are people that they don't know that have not had varicella or they have not been vaccinated. These people are at risk, and when there are patients with either one of the above, then they need to be revaccinated and or given immunoglobulin depending on the case. Remember that when we have a sharp injury, we are at risk for tetanus as well. And tetanus is usually good for about 10 years for clean wounds. For dirty wounds or for dirty sticks, it's really even less. Remember also the post-exposure plans. That maybe when we do this lumbar puncture on a patient that has Neisseria meningitis, and all the staff that have been in contact or that have been around this patient ought to be receiving oral prophylaxis. HIV has been covered, so has hepatitis B. But again, I cannot overemphasize the need for administration of immunoglobulin to this patient. Other risks in areas where Salmonella typhi is prevalent in the third world, especially, it's a risk. There is a vaccine for typhus or for typhoid fever. So if there is an outbreak, certain times of the year, it's good to be preventively vaccinated. And now we also have that polio is making a comeback. So it is advisable to be polio vaccinated as well. Couple of words about tuberculosis. We have covered this as well. The PPE fitting, I have also discussed that. But cleaning of contacts of surfaces where there are these infectious patients is really key for Mycobacterium tuberculosis. Other areas where there is a population that carries tuberculosis oftentimes is correctional facilities, prisons. These are areas where we have people that may have been drug abusers. That is usually crowding, and it is a growing ground for TB. And people that work in infirmaries of prisons and so on are at risk. So extra precautions, using the appropriate respirators and so forth. Laboratory workers, my colleague Manuel has also discussed that part. And it's not properly healthcare workers, but just a good reminder that people that work in zoos, elephants do get TB. And, they have very large lungs, and elephants do cough. And people that work in zoos can get also tuberculosis as well. Remember that staff screening upon hire, many places where TB is prevalent, people get PPD tested every year. People that are converted, they have the option of a yearly x-rays if there is no obvious disease, or then they can use the treatment for the people that have converted to positive PPD. Some places where people have had BCG inoculation that makes them positive for PPD, then these people should get quantiferon tested on a yearly basis. Again, the disposal of contaminated equipment for tuberculosis, the people that handle the housekeeping people with the garbage, this needs to be properly sterilized and disposed of. Another area frequently neglected is occupational exposures to Legionella. Legionella occurs in water fountains. Many hospitals have pretty water fountains in front. Then we have heating areas, showers, saunas, even areas where we have water deliveries. This water can be easily contaminated because it's warm. And there is aerosol in spray. Of course, there is the usual part, which is the cooling towers on top of the hospitals that can really spread Legionella, as it happened in the original of Legionnaire's disease, that the aerosol droplets from cooling towers can travel a distance. So those areas need to be worked on if necessary. So how do we do that? Well, basically it is chlorination, and then there is obviously testing of the water. We do test dialysis water. We should also test water from other areas in the hospital. If you really want to get very hard to it, I mean, you can also test fish tanks with tropical fish that need warm water in some doctors' offices. The biocide treatments, and but again, basically, chlorination of the water is what is really key. And of course, not only the patients but the employees are the ones that are routinely around those areas and can get infected. One more thing about MRSA. This was a very interesting study published in Lancet. The carry rate of MRSA there was a screening of 33,000 healthcare workers with a prevalence of carriers of between 4 and 6%, and between 5 and 1%, depending on the center, had some form of clinical infection. So chronic skin diseases, poor hygiene practices, and having worked in countries with endemic MRSA, including the US, that are risk factors that are associated with the presence of MRSA. People that work in wound care centers. These are many hospitals do screen patients for MRSA upon admission. So remember that transmission from personnel to patients was very likely. MRSA is a very, very infective organism. 93% of 68 studies that undertook genotyping proved that this was a frequent source of MRSA for the patients. So, it's not only protecting ourselves, but we have this duty to protect our patients and our colleagues, of course. So thank you very much for your attention. I'll be happy to entertain further questions afterwards. Yes.
Thank you. Thank you very much, Xavier. So first of all, dear audience, I wanted to say, as always, we're running a little bit late, but I think because the topic is very important and interesting, so I hope that you are enjoying it, and thanks a lot for staying with us and not leaving. Sorry about keeping you a little bit late, but we'll be soon wrapping up. So thanks a lot for asking your questions in Q&A. Our experts responded to some of the questions, but also we wanted to discuss some of the questions that you asked. So the first one will be related to vaccination. We receive lots of questions about various aspects of vaccination for staff. And I think if I sum it up and make it into one question, so basically, we discussed some staff join and we don't know their status on certain diseases. Some staff join and we don't know whether they had vaccination or they had the disease or they don't have. Some staff we also need to monitor, when they had the vaccination, did they have response to it? So it all seems overwhelming, and how to best manage it, how to build the system of staff vaccination, who is in charge of it? Is it the responsibility of the HR together with infection control officer, or who keeps the record? So what are the key steps to build effective, good functioning vaccination system for staff? Xavier, do you want to be the first or Gekong?
It doesn't matter. I'm happy to talk whenever. Can you
Okay,
hear me
Gekong,
well?
I think
Some people were complaining that they could not hear me well. Is it okay?
I think it's okay for me. I think,
Okay.
yeah.
Yeah.
Gekong, yes, please.
Okay. Yeah. All right. Generally, if you have an occupational health clinics, will actually take charge of all these immunization program will be good. But like in my institution, I don't have this occupational health clinics. So we actually infection control with infection control personnel with actually in human resource actually oversight this program.
Okay, and is it good practice to do we test all staff when they join? How do you know, or do you ask them to present documents when they come about their vaccinations and diseases?
Yes, the moment they come aboard, we actually request for documented proof. Those are the tables that I listed. What is called evidence of immunity. Yes, we ask for all these informations and whether at least they need to proceed with the vaccinations now.
Thanks a lot, Gekong. Xavier?
Yeah, I spoke briefly about there is evidence-based techniques on this pull and pull, push and pull vaccination, but certainly the one thing that we see more frequently, it is the complacency that we have. Oh yes, we have a 60%, and you see statistics that go for 2-3 years, 50-60%, and furthermore with the rates decreasing. So I would emphasize having a methodology to approach that. I do concur with my colleague that it's good to screen the patient, to screen the staff when they come in. Certainly, hepatitis B can be something devastating when you get it, and the vaccine is very, very highly effective, and it does last for a long, long time. I mean, it's I got vaccinated more than 30 years ago, and I'm still positive for antibodies. So, and like me, many people. Again, vaccination. In some countries, you have legislation that really protects the workers in the sense that, if I don't want, I don't have to be vaccinated. However, the majority of the places, we can invoke the sense of responsibility that all of us have when we treat patients, right? I mean, the first principle is do not harm. So if that is a difficult to argue point. And then again, it's what I was telling before. Deploy people during season to areas where they cannot harm people, And there are countries that the legislation is very clear. You get vaccinated, your employer can mandate you to get vaccinated, and they can fire you if you don't get vaccinated.
Thank you. Thank you very much, Xavier. You actually slightly touched my next question, which was about screening patients when they come. So based on what you said, let's give clear guidance and best practice. So is it worth checking the status of the patients, for example, before surgeries like HIV, hepatitis, or it's wasted effort? So is it worth it?
Yeah.
Is it not? What's
Yeah.
the best practice?
Yeah. The bloodborne illnesses, it should not make any impact on our management of these cases. So, HIV, hepatitis B, and so on, it's a silly blanket, if you will, because we should not really change our technique. And you can even question there the ethics of doing that, because it's a charge that the patient incurs that there is no need, because we're going to manage the patients anyway. It is a good practice, however, to test the people for MRSA. I mean, to do a nasal screening, because that will impact if the patient has a postoperative infection, for sure. So that definitely there is a worthwhile evidence that this makes sense. The other bloodborne is not going to make any difference.
Okay. Thanks a lot, Xavier. Manuel, specifically for lab, a tricky question. I bet you were not prepared for it. So there are PPE, there is infrastructure, like hoods, etc. You said it's important to use it. So how to actually make staff use it? Any tricks, any tips? How to make sure that they use PPE when no one is looking? Anything that you had in your own lab being the head?
Yeah, thank you, Julia. Yeah, actually, I was answering a similar question on the QA box related to that, but mainly management has to develop strong policies and procedures. And those have to be based on evidence. They have to be developed. People have to be trained. And one of the things that I did and I recommend to labs is to do an ongoing training. Number one, it's not just one time; it's an ongoing. So annually. Second one, I asked the people in my labs and also in the when I visited the labs to post posters. So if you have a policy that people who go into the lab must wear lab coats, goggles, gloves, mask, then you must have that policy or that poster on your door before entering the lab. As well, it is about asking also management, senior management to help you to enforce those policies and just to do a follow-up, monitoring of that. But mainly, the main thing is about developing policies, strong policies and procedures, and science reminders.
Thanks, Manuel. This is very helpful. So we are running out of time, unfortunately. So I'm afraid we need to wrap up our session. We got this feedback from youth that it was informative. This is music to our ears because we were trying. The topic is complicated, and also we had to fit in as much information and advice as possible into this time limit. So I hope we succeeded in this. So we will continue definitely our series of webinars, and we will inform you about the topic of the next webinar. You're welcome to join. Thanks a lot for posting your questions. And let me just remind you that the certificates of attendance will be available within 2 weeks' time. And please make sure that when you exit this webinar, you receive the form on survey on exit and you fill in your name, because in this case, we will be able to send you the certificate. So thanks a lot for joining us today. Thanks a lot for staying longer, for being active. We believe, we hope it was useful for you, that you were inspired to improve certain practices in your facility and better protect your staff. Thanks a lot. So Natasha, anything from you? I think I already covered the survey on exit. That's usually what Natasha covers. So thanks a lot, everyone, and look forward to seeing you on our next webinars. Thank you. Bye-bye.
Thank you.